Hello, my name is Free, and I'll be discussing breast cancer with more emphasis on inflammatory breast cancer, also known as IBC. I'll be talking about the overview next, which will include the incidence and risk factors. 1 in 8 women in the US will develop breast cancer in their lifetime. More than 150,000 new cases are reported every year. About 50,000 deaths are reported annually as well. The incidence is greater in women than in men. IBC is a very rare and very aggressive disease. Accounts for between 1 to 5% of all breast cancers in the US. IBC is most common in African American women between the ages of 30 and 50, mostly seen in obese women, and can occur in men but at an older age. The risk factors include a history of previous breast cancer, family history of breast cancer in a first degree relative, early menarche, nulliparity, first time pregnancy after age 30, presence of BRCA1 or BRCA2 gene. Other risks include obesity, high dietary fat, high alcohol use, and estrogen use. I'm discussing the pathophysiology next. Cancer cells block lymph vessels in the skin of the breast. Most IBCs are very invasive ductal carcinomas, which means they develop from cells that line the milk ducts of the breast and then spread beyond the ducts. IBC progresses rapidly in weeks or months. Diagnosis IBC is either found at stage 3 or stage 4 disease. IBC are frequently hormone receptive negative. Chief complaint and history. So this is a 26-year-old female of African descent, came in with a complaint of severe bilateral breast burning pain, swelling, hard to touch, and clear liquid discharge from the nipples. The history of present illness. The patient is a lactating mother of a 6-month-old baby who reported sudden onset of redness and severe pain and difficulty with breastfeeding from an inverted nipple. Pain is burning, constant, unrelieved with warm compress or analgesics. Denies any personal or first degree relative history of breast cancer. Reports early menarche at age 9. Reports taking birth control pills for 10 years starting from age 16. Denies previous breast surgeries or biopsies. Denies breast self-examinations or mammograms. Reports occasional alcohol consumption. Reports a high fat diet and a sedentary lifestyle. Upon physical examination, the patient's vital signs were found to be within normal limits. General appearance, the patient is well developed, well nourished, healthy appearing female. The neck is supple, no cervical adenopathy. The breast examination was done in sitting and supine positions. There was remarkable changes to skin of bilateral breast. So there were bilateral breast edema. It was warm to touch. Erythema affecting more than a third of bilateral breasts. The skin is reddish pink, purple, and bruised. Skin around the breast is pitted and have ridges like the orange skin, called orange. The nipples are inverted and very tender with clear liquid discharges. No tumor was felt during exam. There's positive bilateral axillary infraclavicular and supraclavicular lymphadenopathy. The lungs were clear to auscultation. Heart rate and rhythm were within normal limits. The chest wall was symmetrical, no tenderness over intercostal spaces. The primary and differential diagnosis. So for the primary diagnosis, this patient was found to have inflammatory breast cancer. The differential diagnosis include mastitis, which have the same symptoms with inflammatory breast cancer, intraductal papilloma, ductal carcinoma in situ, fibroadenoma, and fibrocystic breast disease. Diagnostic testing. So the testing will include testing for abnormal levels of HER2 protein, the diagnostic mammogram, ultrasonography, an MRI, PET or CT scan. Biopsies can be done, and bone scan to determine metastasis of the disease. So for treatment, so the patient was prescribed some vitamin E, 400 units of vitamin E daily. Patient was prescribed danazol 100 to 200 milligrams BID for severe pain. Some diuretics were prescribed as well, oral contraceptive, supplemental progestin. And referrals were made to gynecology, oncology, dietitian, and physical therapy. And for treatment of the cancer, it's usually a multi-modal approach. First of all, there's a systemic chemotherapy that's given to help shrink the tumor. Neoadjuvant chemotherapy is also given before surgery. Then the targeted therapy is also another alternative if the patient is found to have to be positive, to have positive HER2 protein, so that they are given anti-HER2 protein therapy. There's also hormone therapy if the tumor is found to have estrogen or progesterone receptors. Surgery, of course, is another option, and it could be lumpectomy that could be done, but in this case it's usually modified radical mastectomy. There's radiation therapy that comes right after surgery, and adjuvant systemic therapy is given, which could be a combination of the targeted therapy, hormone therapy. This is just to help reduce or at least prevent reinvasion. For patient education, patient will be advised to avoid trauma to the breast, so wear a firm bra day and night with a nipple padding to collect the discharges. Eliminate stimulants like coffee, tea, chocolate. Patient will be educated on the side effects of danazol, which is prescribed to help with severe pain. Patient will be advised to get enough rest, mild exercises. And for patients who are going to be going through chemotherapy, surgery, will be educated on postoperative lymphedema, that should be expected. Limited range of motion to the shoulder. Then side effects of chemotherapy like alopecia, nausea, vomiting, stomatitis, leukopenia, fatigue, and the side effects of radiation therapy, which are basically skin reactions. And the clinical practice guidelines according to USP STF 2016 recommendations for populations, women ages between 40 and 49 years old, women between 50 and 75. So they're supposed to screen every 2 years. Women above 75 are not supposed to screen at all. And the rest of recommendations can be seen here. And this is the end of my presentation. Thank you. And these are my references as well. Thank you very much.